longer on. All right. Welcome everybody to IPDLN 2020. This section is focused on presentations from the abstract session with a focus on aging. My name is Susan Bronskill. I'm a senior scientist and program leader for the Life Stage Research Program at ICES in Toronto. And I'm really looking forward to chairing this session today. I first will read a brief introduction of each speaker, and then they'll proceed with their presentation for 10 minutes each. And then at the end of the session, there'll be 15 minutes for questions. So the first speaker is Dr. Lara Harvey. She's a geriatric epidemiologist and research fellow at Neuroscience Research Australia. Her research focuses on the conduct of innovative data linkage studies to inform improvements in health service delivery and health policy for older people with and without dementia. And she's going to talk about looking at identifying frailty in hospital admission data and its association with adverse outcomes in surgical patients. So over to you, Lara.
Thank you. So I'd like to start by acknowledging my co-authors on this study, and they're listed on the title page below. Okay, so as the population ages, increasing numbers of older adults are undergoing surgery. Surgery is now common in older people. So for example, in England, over 5 million people aged over 65 years are admitted to surgery each year. In Australia, from where I am, of the just over 2.5 million hospitalisations involving surgery, 39% were for people aged over 65 years, although they only comprise about 16% of the population. Outcomes from older people are known to be worse than for younger people following surgical procedures, and identifying which patients stand to benefit from surgery can be challenging. Oops, going backwards. So frailty has been recognised more recently as a major contributor to poor outcomes following surgery. And it's been described as the most problematic expression of population ageing. It's defined as a cumulative multi-system decline in function, where small stresses, such as a minor surgery, can result in a disproportionate deterioration in health status. And it's increasingly being recognised, and this is important to us as epidemiologists, as an independent risk factor for adverse outcomes, which is quite separate from age, sex, and comorbidities, for which we normally risk adjust in our models. And frailty is common. So pooled estimates from 4 Australian studies suggest that 21% of the older Australian population are frail, and a further up to 48% are classified as pre-frail. Oops, keep doing that. But defining frailty, it might be common, but it's actually quite difficult to define, and it's been problematic. So around 2001, Linda Fried conceptualized frailty as a phenotype, which can be identified by 5 different clinical conditions: weakness, slowness, low physical activity, poor endurance, and weight loss. And this then she classified or categorized into 3 categories, being non-frail, pre-frail, and frail. So that's a very clinical conceptualization of frailty. Whereas in the other corner, Professor Rookwood took a completely different way of conceptualizing frailty in his cumulative deficit model, in which he composes an index, which is basically just the number of deficits divided by the total possible number of deficits. So as epidemiologists or people working with administrative data, this has a much more immediate application. However, the 2 groups don't necessarily agree on how to define frailty, and clinically also, it's not surprising that there are a plethora of tools that define frailty, all subtly different or quite different. So the problem with assessing frailty clinically is it can be quite time consuming, and it's certainly not routinely undertaken on all admissions. So using data available from electronic medical records can potentially provide the opportunity to routinely screen for frailty at the time of admission. And this has recently been made possible by a relatively newly published study. It was new at the time that I started looking at my study, that actually developed a hospital frailty risk score using ICD-10 electronic data, published to great acclaim in the Lancet. And it was validated in emergency admissions for acute hospitals in the UK and at the time in Canada also. So it rose the question for me, is it of equal use for surgical admissions? So the aims of my study was to assess the performance of this new hospital frailty risk score in assessing the prediction of adverse outcomes, 30-day mortality, prolonged length of stay, 28-day readmission, to compare its performance against the performance of the Charleston Comorbidity Index, which we commonly use for risk adjusting in our models for older people, and also to determine the optimal age groups and look back periods to use it if we are going to start using it. So hospital and death data for just under 500,000 individuals aged 50 years and older admitted for a surgical specialty to a private or public or private hospitals in New South Wales was linked for a 5-year period. I calculated the hospital frailty risk score using the 109 diagnosis codes and associated weights as described by Gilbert in the Lancet paper, categorized into low, intermediate and high frailty risk. I calculated the Charleston Comorbidity Index using the Klein coding algorithm and used the weighted CCI score, again categorized into no comorbidity, intermediate and high comorbidities. And for both scores, I calculated using both a 2-year and a 5-year individualized look-back periods. Oops. And for each of these, I fitted several logistic regression models to just check the incremental impact that using different measures had on the ability to discriminate for an outcome. So starting with base model, age and sex only, adding in the frailty score, the comorbidity score, and model 5, which was the full model, was the same models used in the original Lancet article. I used area under the receiving operator curve and the AIC to assess these models. Sorry, I keep going backwards because I have to use my thing on my mouse rather than the button. So of the 500,000 patients with a surgical admission, over a third were actually aged over 75 years, again clarifying that surgery in older people is increasingly common. 2/3 of patients had a hospitalisation in the previous 2 years, and I was able to calculate the score for those patients, and over 80% of patients if I used a 5-year look-back period. 3/4 of this cohort were classified as low frailty, and only 7% as a high frailty risk. So this cohort is a representative of a fairly well cohort. Not surprisingly, the proportion of patients identified with a high CCI or frailty score and those experiencing adverse outcomes increased with age groups, as we would expect. Oops. Okay, so what did I find? So not surprisingly, both high frailty and high CCI or high comorbidities were strongly associated with 30-day mortality. And you can see the area under the receiver operating curve shows that it actually provides a very acceptable discrimination, but the frailty score really did not perform any better, in fact, marginally worse than the CCI score, and having them both in the model performed marginally better than just using one alone. Interestingly, when you apply it to the younger age groups, it actually provides good discrimination. So it actually works well in the discriminating in the younger age groups, which it's not previously been applied, and that reduces to just acceptable discrimination in the older age groups. Oops. Moving on to prolonged length of stay, again, there's a really strong association between frailty and length of stay. However, when you look at whether the model is able to discriminate, it provides really poor discrimination and is really not appropriate for use for looking at length of stays. Interestingly, irrespective of whether you use a 2-year or 5-year look back, doesn't improve the model, and it's not appropriate for use within any age group. Similarly, 28-day readmission, it performed equally badly, providing poor discrimination and not providing any benefit. And neither CCI nor the Frailty score actually is acceptable discrimination. And again, it doesn't improve with look back or age group. And I guess we really shouldn't be surprised, because if you read very carefully in the original Lancet article, my results are not dissimilar to what they found, where the hospital frailty scale actually didn't provide acceptable discrimination for frailty within their data set, except when it was added with all the other components. And also, it also was not particularly well associated with clinical frailty. So when they looked at kappa—
1 minute, Amy.
Thanks, Susan. When they looked at the kappa scores with both the Freed and the Rockwood classifications, it also didn't agree. So we're not entirely sure that the hospital frailty scale actually is measuring frailty, no matter how you define it. So in conclusion, although the new score was independently associated with all 3 outcomes of the surgery cohort, it really didn't provide an awful lot of benefit above the CCI, which is more commonly used when looking at mortality. And it certainly wasn't as appropriate for use when looking at hospital stay or 28-day readmission. Adding a longer look back period to 5 years didn't improve performance, and neither was it better in any other age group. And so the question, I guess, is it then of use of looking at complications? Because we know frailty is quite strongly associated with complications in hospital. And as far as I'm aware, that's yet to be assessed for this model. And if I can get it to come up, I'd just like to thank the Ministry of Health and the Registry of Births, Deaths and Marriages for the provision of the data, the Cheryl for conducting the data, and just to say, if anybody is interested in reading this in any greater detail, it's recently been published in Age and Aging, or please feel free to contact me, and my email address is on the screen there. Thank you.
Perfect. Thank you very much. I forgot to remind everybody at the beginning of the presentation, please, if you have questions as the speakers are going, to add them to the chat that's open on the IPDLN portal. And we'll have 15 minutes at the end to go through the questions for all of the presentations combined. So we'll quickly, I'm very concerned about the time limits and the whole session shutting down on us. So I think if we can make it to the 15 minutes of questions, that would be terrific. Our next speaker is Dr. Rebecca Mitchell. She leads the Health Outcomes Research Stream at the Australian Institute of Health Innovation at Macquarie University. She's a psychologist and injury epidemiologist, and her research focuses on the conduct of large-scale epidemiological and mixed method research to guide improvements in health service delivery and health policy. And she's going to talk to us about trajectories of hospital readmission after a fall injury for older adults living in aged care or the community. So please, Dr. Mitchell.
Thanks, Susan. I'd just like to acknowledge my co-authors as well, who helped conduct this research. As many of us know, fall-related injuries are one of the leading causes of hospitalisation for people aged 65 years and over. There are often many causes of fall-related injuries, some intrinsic to the individual, such as their comorbidities like dementia, with others extrinsic to the individual, such as environmental conditions like slippery surfaces. As many people age, their age-associated health conditions can increase, with older people consuming around 47% of hospital beds in Australia. For this study, we were wanting to explore the frequency and course of hospital admissions for older people after an initial full injury hospitalisation, and to see if individual characteristics differed for people that had different hospital admission profiles. The aim of the study was to examine the trajectory of hospital readmissions over a 4-year period for older people who had a fall-related injury hospitalisation in the previous 12-month period in New South Wales, Australia. Older people living in aged care and older people living in the community were examined separately to identify characteristics that were predictive of trajectory group membership in both of these settings. To conduct this study, we used linked hospitalisation and aged care data. We identified an index hospitalisation as occurring during 1st of July 2008 to 30 June 2009, which represents a financial year in Australia. We then examined 4 years of data after the index admission period to 30 June 2013. We included people aged 65 years and older who had a fall-related external cause code and a principal diagnosis of injury, identified using diagnosis coding in the hospitalisation records. We identified 16 comorbidities using the Charleston Comorbidity Index and identified dementia separately, along with depression, all using a 12-month look-back period and up to 50 diagnosis codes in the hospitalisation data. For residents of aged care, we also had information on their activities of daily living and mobility assistance requirements. People were identified as living in aged care if their index hospital admission for their fall injury occurred after their date of admission into aged care. Otherwise, the person was identified as living in the community. To analyse the data, we used group-based trajectory modelling to examine the course and frequency of hospital readmission over a 4-year period. For the trajectory modelling, the outcome was the number of hospitalisations in each 6-month period, grouped as 1 to 2 readmissions, 3 to 4, and so on to 11 or more readmissions. We used a censored normal model, and model selection was selected for between 2 to 5 groups using a quadratic equation. For aged care residents, a 4-group trajectory model was the best fit, indicated by the lowest Bayesian information criteria and the best average posterior probability of group membership. For community living residents, a 5-group trajectory model had the best fit. After the trajectory groups were identified for the aged care and community living residents, we then conducted multi-nominal logistic regression to examine predictors associated with readmission by trajectory group for both the aged care and community living residents. For the index fall injury-related hospitalisation, 21% of older people that fell and were hospitalised were living in aged care, and 79% were living in the community. Aged care residents had a higher mean age at index admission than community living residents, and had a higher proportion of females who were hospitalised at the index admission. For the community living residents, 43% were later admitted to aged care during the 4-year period after their index fall injury hospitalisation. Looking at the hospital readmissions for the next 4 years in 6-month blocks, for the aged care residents, there were 4 trajectory groups identified, and I'll just indicate some of their distinguishing characteristics. The black line shows the low readmission group, around half the aged care residents. 38% were aged 90 years or older, 59% were living with dementia, 27% had a high dependency for activities of daily living, and around a third required assistance for mobility. The orange line shows the moderate declining group, around 19% of residents. 53% were aged 80 to 89 years, 9% had 3 or more comorbidities, 45% were living with dementia, and 35% had moderate dependency for activities of daily living. The blue line shows the moderate chronic group, around 27% of residents. 43% were living with dementia, and also 43% had a low dependency for activities of daily living. The red line shows the high readmission group, less than 1% of aged care residents. 16% had 3 or more comorbidities. 47% had low dependency of activities of daily living, and in this group, 26% experienced major depression. These are the results of the multi-nominal logistic regression showing predictors of trajectory group membership for aged care residents. The reference group is the low readmission group. And just to highlight a couple of results, compared to the low readmission group, the moderate declining group were up to 4 times more likely to be hospitalised following 3 or more additional fall injuries, and also had a higher likelihood of experiencing major depression. Again, compared to the low readmission group, the high readmission group were up to 8 times more likely to be hospitalised following 3 or more fall injuries, and were up to 5 times more likely to experience major depression. Looking at the hospital readmissions for the next 4 years in 6-month blocks for the community living, there were 5 trajectory groups identified. The black line shows the moderate declining group, representing 9% of community living residents. 51% were aged 80 to 89 years. Around a third had 1 to 2 comorbidities and 12% were living with dementia. The orange line shows the chronic group, also 9% of the community living. Over a third were aged 70 to 79 years. Another third had 1 to 2 comorbidities and 5% were living with dementia. The blue line shows the low constant group, and this represented half of the community living residents. 45% were aged 80 to 89 years. Around a quarter had 1 to 2 comorbidities and 8% were living with dementia. The red line shows the low declining group, around a third of the community living. 18% were aged 90 years or older, 28% had 1 to 2 comorbidities, and 17% were living with dementia. The green line shows the high readmission group. It only represented 0.4% of the community living. 40% were aged 80 to 89 years, 20% had 3 or more comorbidities, but only 1% were living with dementia. And the results of the multi-nominal logistic regression showing predictors of trajectory group membership for the community living population. The reference group is the moderate declining readmission group. Again, just highlighting a couple of results. Compared to the moderate declining readmission group, the low declining group had a higher likelihood of living with dementia, sustaining a hip fracture during their index admission and living in a rural area. The high readmission group had up to twice the likelihood of having comorbidities compared to the moderate declining readmission group. Although it was a large population-based study, there were several limitations. We only had access to in-hospital mortality data, so we're unable to examine long-term survival. Only health conditions related to the episode of care in hospital are recorded in the hospitalisation data, so we're likely to under-enumerate the number of health conditions experienced by an individual, but we did use a 12-month look-back period in this study. No data validity assessment was able to be conducted as well for the hospitalisations records. So to conclude, identifying trajectories can be useful to identify characteristics of repeat hospital users and to start to describe some of their readmission patterns, particularly over a longer time period, such as the 4-year period that we used in this study.
1 minute.
Thank you. There could be potential to reduce hospital admissions, particularly related to chronic health conditions that were experienced by so many of the older residents. In aged care, this could be through the use of hospital avoidance programs, so treating the individual in the aged care setting, but this will obviously have resource and staffing implications. In community living, this could be through access to hospital in the home and home-based aged care services, but again, also with resource implications. And just a couple of acknowledgements. I'd like to acknowledge the funders of this study, the Data Linkage agencies and the Sachs Institute for the use of SHORE to warehouse and analyse the data. Just like to thank the data custodians, and we've also published this work late last year, and here's the reference for this research published in International Osteoporosis. Thanks a lot.
Thank you very much, Dr. Mitchell. I'm looking forward to asking you some questions about the trajectory models and what some of the characteristics of those graphs mean as we go through the presentations. So our final and third presentation today is by Heidi Welberry. Heidi is a PhD candidate with the Center for Big Data Research in Health at UNSW. And she's been using linked data to understand trajectories of healthcare use among older Australians at risk of dementia. She has over 15 years experience working with both federal and state governments, using data to inform and evaluate programs and policy. Her research interests include dementia, health services research, social care, primary health care, population aging, and novel methods for understanding patterns of healthcare use, such as Markov modeling and machine learning. And Heidi is going to talk to us today about measuring dementia incidence in routinely collected administrative data. Over to you, Heidi.
Thanks, Susan. I would also just like to acknowledge my co-authors on this paper, which I actually don't have listed there, but Louisa Jorm, Henry Brodarty, Benjamin Su, and Sebastiano Barbieri. I'm just going to start with a little bit of background to dementia in Australia. As it is across the world, dementia prevalence has been increasing. So currently it's estimated that around 500,000 Australians are living with dementia. But this is expected to increase to over 1 million by the middle of the century. It's currently also the second leading cause of death in Australia. But the issue we're faced with here, which also is an issue in other countries, is that there isn't a gold standard way of measuring dementia incidence in the population in Australia. And particularly when looking at dementia research and trying to conduct prevention trials and studies understanding risk factors for dementia, dementia develops over decades rather than years. So follow-up of trials or studies can be very challenging and expensive. So linked administrative data really offers a lot of potential for both monitoring dementia in the population, but also value adding to long-term follow-up of trials and observational studies. So the aim of this analysis that I'm going to present today was really to provide some guidance on the current usefulness of administrative data sets in the Australian context for measuring dementia incidence. Sorry, I'm doing what you're doing, Lara, going the wrong way. So the two research questions that I'm going to address are how do age-specific dementia incidence rates based on administrative data compare to other published estimates based on clinical assessment? And then I'm going to look at the different data sets available in Australia and work out whether you get different patterns of incidence if you use different data sets. So in order to conduct this study, it's based on a large cohort study that's been running in Australia for quite a long time now, called the 45 and Up study. This recruited over 250,000 people in New South Wales, so that's the state highlighted in red there in Australia, back in 2006 to 2009. And they entered the study by completing a baseline survey, but then they also consented for ongoing data linkage. So for this study, we linked the baseline survey data to a range of data sets. I'm not going to go into these in detail, but just to note that there were, we had access to aged care data, which included assessments for accessing aged care, and then also assessments to determine level of residential care need once people entered residential care. So we used these data to look for dementia diagnosis. So just to note up front, the baseline survey did not ask specifically about dementia, but we could then try and pick up dementia diagnosis within the aged care data. Important to note, not using the primary care claims because there is no diagnosis codes attached to claims for visits. But we could also look in medications for use of dementia-specific medicines. So that includes cholinesterase inhibitors and memantine. And then also within hospitalisations and death certificates based on ICD-10 coding. So what we did was we had a 2-year washout period and started looking for dementia at 2 years following recruitment to the 45 and up. So following the participant filling out a survey, and that survey included a whole range of information on their socio-demographic factors, as well as health behaviours and comorbid conditions, self-reported conditions. We excluded people who had died before the study entry date, but then also anybody who had a dementia diagnosis in the available data sets prior to that point were excluded, so that we had a cohort that we were then assuming had no dementia. We then looked for a dementia diagnosis in the 5 data sets listed there, and we had a cutoff point of the middle of 2014. So we were then looking for calculating age-specific dementia incidence, and then incidence rate ratios across a range of potential risk factors from the 45 and up baseline survey. So what did we find? This graph may be familiar to anyone who is researching the dementia space. So this is the dementia age-specific incidence rates for dementia. The red line is what we found in the 45 and up study. So it is following a pattern that is actually pretty consistent with what we were expecting to find. And I'm comparing this here to rates based on the World Alzheimer Report from 2015. That was a large meta-analysis of other clinically diagnosed studies, so studies that had used clinical diagnosis. So you can see that it tracks actually fairly close to what we would expect, but with a little bit of under-reporting compared to those rates. I'm also comparing it with the purple line to the only other study available at this point that has used linked data, administrative data in Australia, and again, it's actually fairly consistent. That was only conducted in the 80-year age groups. So overall, the coverage was actually fairly good in terms of detecting the proportion of cases we'd be expecting when you got into those 80 to 89-year age group, picking up, getting close to 90% of the cases that we would be expecting to pick up. But you can see that at other points, other age groups, the coverage seemed to be slightly lower. So particularly for early onset dementia, it wasn't picking up nearly as many cases as we would expect. So why might this be? This is now looking at age-specific dementia incidence based on each of the 5 data sets individually. And you can see that they all have slightly different coverage across the age groups. And the odd one out really is the medications data. So this really tails off in the older age groups, suggesting that, that it is much more likely to be prescribed and to claim for the dementia medications in the younger age groups compared to the older age groups. There's also some variation across the other ones, and you can see the importance of the aged care data sets in some of the older age groups. So I guess the potential impact of this is one of the things that we wanted to look at. So what we did is modelled incidence rate ratios for a range of potential risk factors across the 5 data sets individually. So we actually looked at a lot more factors than I've listed here. So this is just some selected characteristics to illustrate what was going on. And you can see that one of the concerning things was that there's some differences in the direction of relationships occurring. So for sex, for example, which has been in other research found to be inconsistently related to dementia incidence. When you look at hospitalisations, being male seemed to be a risk factor, but actually within residential care, it seemed to be a protective factor. And this seems to be because of the different likelihood of males to be picked up in the different data sets. So similarly, marital status is also another factor that is related particularly to people's use of social care in Australia, so aged care in terms of either whether you use aged care at home or residential care. And again, we can see some really inconsistent relationships occurring. So significant findings in opposite directions. And then diabetes is fairly well understood to be a risk factor for dementia incidence. But again, we also see inconsistent directions of relationship here. So in looking at medications alone, it actually seems to be protective for dementia, which seems odd. And it's likely that people with diabetes are perhaps less likely to have dementia medications prescribed, possibly due to contraindications or polypharmacy related concerns. Other factors though, such as stroke and Parkinson's disease, seem to be much more consistently related across
Hi, I missed the 1 minute mark, but please go do another 30,
sorry,
do
Susan,
another 30 seconds. I was looking at all of your risk factors.
Pretty much last slide anyway, thank you. Okay, so just to conclude, the patterns of incidence across age groups was consistent with clinically diagnosed estimates when using multiple administrative data sources, best in the 80 to 89 year age group. But measuring dementia as an outcome using a single data set may lead to biased results due to differences in coverage patterns. Combining the data sets does appear to be more robust against these biases, and then checking for consistency will give greater confidence in the results. So just to note, this publication has come out now, and you can, if you look that up, you'll find much more detail on more risk factors. And then I just wanted to acknowledge the funding and also my supervisory team and everyone involved in the collection and linkage of the data. Thank you.
Thank you very much, Heidi. That was also excellent. So 3 well-timed presentations. That's terrific. It leaves lots of time for questions, and I have a few myself. I've been monitoring the questions as they come in on the portal. So we'll give people a little bit of time to enter questions on the last presentation, and perhaps we can start with the first presentation, and I'll try and balance across all 3 so that we can have a robust discussion. So Dr. Harvey, there were some related questions for you that came in through the chat. One theme was related to selection bias in looking at surgical patients in your study. So specifically, were there concerns that the frail individuals might not be selected for surgery? And what you thought about that, as well as potentially there being some ceiling effects in your findings.
Okay, so sorry. I'm sounding like I've got COVID here, but it's not, it's just a lack of speaking to anybody recently. So basically, actually, the people that were selected from the administrative data set were those that were admitted under a surgical specialty. So they may or may not have had surgery. So I don't think we excluded people that didn't have surgery because they were frail. Anyone under Australia that has a surgical type complaint gets admitted under the surgical specialty. So I've included across the board everybody that was admitted for a surgical specialty.
Okay.
I probably didn't make that clear. It's more clearly expressed in the paper.
Did you do any analyses to look at different surgical strata? So the types of surgeries that people were admitted for?
Okay, so for this one, yeah,
go ahead.
Absolutely. So, and it's an ongoing piece of work. So I have looked at it by different surgical cohorts. So for example, hip fracture surgery is something we do a lot of work around. And the results are very similar in that it doesn't seem to add much beyond what the Charleston does. The other thing we need to look at, which I'm about to do, is look at whether it's any better at predicting emergency versus elective surgery, whether that would make a difference. But the point behind this originally was to see whether, as a routine screening for every patient that presents for surgery, if they could have a score to alert surgeons to the fact that they might be frail and therefore they may need to integrate some care, either optimization pre-surgery or special care after surgery. So we were really interested to see whether it could just be a quickly create a tool for all patients admitted under a surgical specialty. It doesn't appear to be adding much benefit for that role. Whether it's now more appropriate to look for it as a tool by certain surgical specialties, certainly, but I certainly wouldn't be recommending going ahead and risk adjusting using it for big studies that aren't looking at special population groups.
And I think that ties into another thread of the questions for you, which was if the HFRS, am I getting the letters in the right order, were if it was validated in a population over 75. There were some questions about why you looked at it in younger populations. And then a related question on if it's not working, do you have any thoughts on what might be used as an alternative?
Okay, so yes, so frailty, I think, it is common and it is also exists in people under 75. So yes, the original cohort study that they did, so the Gilbert study, looked at those at age 75, and I was just interested to see whether, in fact, given that it performed so poorly, even in their study, whether it would be of utility in a broader age group. Because I think, and I'm very sorry if there's any surgeons watching this, but surgeons we work quite closely with, may not necessarily think of frailty in the younger age group. So it's whether it can be the attributes of frailty, if we can pick them up administratively, might prompt that in a different age group. And that's where it was surprising that actually it does work better in the younger age groups, who people obviously have more comorbidities. They have more of the conditions that contributed to the frailty index. But it may not be prompted in the surgeon's minds that these may be a high-risk population. And so it did actually discriminate better in that age group. And that's why we're interested in broadening the age group that we looked at for that. So that was part one of your question. What was the other bit?
Second part was if there are, if it doesn't seem to have predictive ability, are there other alternatives that you would recommend? And I know that sometimes falls in the tension of the categories of frailty versus the accumulated deficits index approach.
I mean, I think that's kind of a really the holy grail of frailty research at the moment. So anybody out there working in this space, if you're able to come up with a better index, please publish it, because we'd all love to use it. I think, and it's certainly work that we're trying to get our heads around, is coming up with better ways. I think the concept of being able to identify frailty is so important. It is different from comorbidity. Comorbidity has been working very well, and it does work well for mortality. So if we can come up with some sort of index, whatever it's measuring, but measures these people that are vulnerable to adverse outcomes on admission, I think that would be fabulous using administrative data. So please go ahead and try. And we're all working on getting something that we can all use for our risk adjustment models. And no, I don't recommend anything currently.
I think the challenge sometimes is, I know there's ongoing work in Canada in this area, and the challenge is sometimes what's available in the ICD codes in a standardized way may not be capturing the critical pieces of frailty.
And you can be using other records. So this is just very much looking at point of admission to hospital, which would be easily implementable. Can they get information from previous records? But there are studies now that are using AI, clever AI techniques that are using a whole lot of, medication records plus GP records plus other result records that are coming out with much better comorbidity, frailty indexes that are predictive and apparently quite strongly predictive. It's a matter of having them readily available on the wide scale that I think is still missing.
Yeah, for population-based research. Okay, Rebecca, there are two questions, and they're coming in out of time order on my screen, and I'm trying to just make sure I'm not missing anybody's questions. The first question for you related to whether you had any information capturing the severity of the falls and how you dealt with that in your models. And The other question, which is similar to my own, which was whether you could elaborate a little bit on how the group-based models work. So what you're doing when you construct those groups, and again, what those beautiful graphs you made were actually showing, in particular, the one that funneled towards the end.
Okay, so in relation to the severity of the fall, we didn't have any information in the hospitalisation data around height of the fall or anything like that. We did have information about kind of fall characteristics. So if someone fell on a slippery surface or that type of thing, that we did look at in the paper. I don't have all that information to hand. In relation to the group-based characteristics, the trajectory modelling, normally trajectory modelling is used for longitudinal studies. So you might be looking at repeated measures over time. All we used it for was to help us characterise the characteristics of our study cohort. And I guess it's kind of a bit like cluster analysis. You're just clustering together groups of people with similar characteristics, except in this case we have an outcome variable, and the outcome is looking at, in this case, it was the number of hospital readmissions over a 4-year period. So it's just clustering together common characteristics of people that had the same kind of hospital readmission profiles. And then we just go in and once it's clustered together, once it's identified the common characteristics of individuals using the trajectory modelling, I then just take the group variable that's created through the trajectory modelling and add that to our hospitalisation data, and then just descriptively describe the characteristics.
So in your graphs, and I don't think we have, I don't know if we have the tech capability for you to even put your presentation back up again, but I noticed in one of your groups, I think it was in the community setting, your highest risk group, over time, the pattern of falls seemed to funnel. So it looked like they were up in the 3 to 4 falls, and then it narrowed over time. Is that because they've the highest risk of having more falls is in that early period after the initial discharge?
I guess so, and certainly for some of the groups, some of the clusters of fallers, we did have quite a few groups that had repeat falls during the 4-year period. So some of them up to 3 falls. As well, though, some people, although I don't think it was in that high group in the community, but we do have some people dying during their stay in aged care, and so they're dropping out of the analysis, so can't then be included in people who readmitted. Initially, it was one of the unfortunate things for this study is that we didn't have mortality identified outside of the hospital admission records. It just wasn't available for this study. But I'm guessing that what we could have done is excluded all the deaths initially from our cohort. But I was in 2 minds about doing that because we did have some people initially who fell multiple times and then died, and then we wouldn't be capturing their groups or their trajectories in our modelling.
Okay. And then there's been lots of time for lots of questions for Heidi to come into the discussion, and I think we'll try to take them in time order. So there were some clarification questions, Heidi, related to whether or not your approach would allow you to look at different types of dementia, or whether you had to use a broad catch-all term for the population. And another one asking for some clarification regarding the drugs, and using the acronym PBS, which I'm assuming is the acronym for the drug database in Australia, or that you used. Okay.
Yeah, no, great. So I guess the short answer to the first one is no. Like, you can differentiate different types of dementia in you know, many of those data sets, but the capture of specific types is not great. So it's probably better in hospitalizations and the death certificates, but actually not very good. Within the aged care data, it really wasn't specified in much more detail than dementia to be able to use it in any meaningful fashion. In terms of the drug types, yes, I just sort of skimmed over the anticholinesterase inhibitors. So there are 3 approved in Australia through the Pharmaceutical Benefits Scheme, which is my PBS acronym. So that's the Australian government funding for medications, and when somebody makes a claim against that, it's recorded. So they are donepezil, galantamine, rivastigmine, and then there's also a 4th dementia-specific medicine called memantine. And I'm sorry if I pronounced them wrong.
Yeah, that's right.
That was sort of as close as I can get, I think.
Then there were also some questions about, you know, the small gap that you showed in terms of your estimates versus some of the international estimates. So there was one question about whether you looked at self-reported dementia in the 45 and up study, and another question just wondering if you might speculate on where that gap might be, like why you might be a little bit lower with your data.
Okay, so yes, unfortunately in the 45 and up study and the baseline survey, they didn't ask specifically about dementia. So it could have been self-reported through the free text fields, but we didn't have access to them at the point of doing this study. So that was a limitation in terms of we weren't able to identify it from the survey, which would have been really interesting to look at. In terms of, I guess, the slight differences, I think we were expecting that the administrative data would not capture all of the cases. So we were expecting that the curve would be slightly under the clinical estimates. I guess we were, you know, reasonably pleased to see that it wasn't too far under. I think I noticed in the comments, I think it was Rachel had asked about the difference between the other Australian study. So, and that one was actually slightly under our curve. And I think, yes, that could be, that study was based on the Australian Longitudinal Women's Health Study, and it was specific to women. So that could explain one of the differences. We didn't see a huge difference in the dementia, age-specific dementia incidence by sex, but there were slight differences that could have, they could explain that somewhat.
I think we're very close to the end of time. I see our little reminders from the tech support popping up for us. I think that hopefully the questions are there for the presenters to go and look at. If there are individual people that you can respond to, or people that I missed asking questions along the way. And I'm assuming that all of you might not mind having people email you directly if they had follow-up questions about your presentations or studies as well.
Sure.
So, and there are lots of positive comments just on all 3 presentations being terrific. And I'd like to echo that sentiment as well. So thank you all very much for presenting today. Lots of food for thought, and we have 10 seconds left. So perfect timing. Thank you all.